where exactly does the efficiency come in here? So I'm talking about the MAKO. As you all know, it's been speaking about this last 2-3 days. There are 3 types of robots: boundary control like the Navy and the Cori, semi-autonomous like the MAKO. So there's a human interaction still there, and the fully autonomous like the QVIS, where the robot is doing most of the work without the thing. So I'm not going to show these. You've been seeing these robots in the last 2-3 days. Quickly, because you haven't seen any MAKOs in the last 2 days. So this is a robotic arm. I still have control over it, but it's within my haptic boundary in that particular planar workflow. So we're working within those boundaries in that particular plane. So again, a different type of classification is again image-based or imageless. Again, I'm not running through this, but we're talking about the striker, which is a CT-based. So right now, the advantage here is with the MAKO, I can do the total knee, partial knee, as well as the total hip. And again, as I told, as Vaidya sir also mentioned, the marriage made in heaven is between the partial knee and the robots. So what's the need? Do we really need it? We know that AMOE can be managed with unis or total knee, either of the two. But unis have faster rehab, reduced blood loss, and fewer perioperative complications. And our own study, where we have studied more than 3,000 knees, which were done with TKR, we studied the wear patterns and the ACL, and we found that 47%, it's a huge number, were amenable for uni if you take the Oxford criteria. So this is our paper where we published just last year. So, but still, they're not very popular in India, probably because of the increased risk of revision. So, but if you see all the papers, the outcomes are really fantastic. 98% survivorship in the 1500 by Berend et al. Sward and Price et al. Showed 91% at 20 years. So the question is, are revision rates really high? Well, probably because it's a very challenging procedure, demanding procedure with restricted field of vision. Threshold for revision is much less. If you get a uni patient with pain versus a TKR patient with pain, you're probably going to jump for a revision in the uni patient rather than the TKR. TKR guy, you'll probably ask him to do some exercise and come back again. But you don't have that threshold for a uni. The potential for technical errors is high in unis. Poorly implanted partial knees will definitely fail earlier. So at the end of the day, successful unis depend on 3 things: accurate component positioning, soft tissue balancing, and overall limb alignment. So there's a lot of calculations that need to be done. So that's where the robo comes into the picture. So I'm talking about RAPCA, we call it RAPCA, so robot-assisted partial knee arthroplasty. So as you know, it's a technically demanding and slick surgery, and robotics prevents overstuffing, which is one of the most common reasons for lateral compartment wear, if you overstuff the medial compartment. So you can avoid that with the robot. So the 3 core features in the MAKO partial knee: the enhanced planning, which I showed you earlier, the dynamic joint balancing, I can move my implants around to get a perfect balance, and of course the haptic guidance in the execution of the case. So it's a 3D planning where you're doing the segmentation like this. All these slices are put together by the technician, and they create a 3D model of that particular patient. So as we've seen earlier, we get this 3D model before the case even starts. So I can actually plan my sizing of my implants beforehand. This is of course a TKR video, but the same thing for a partial knee. So it's the segmentation is done, you get a 3D anatomy. It helps with implant sizing and alignment to the bony anatomy. The OT layout, as you've seen, I'm not going to run into this. Bone registration and dynamic joint balancing in the 4 post captures I've already shown in the video. The graph balancing, again, it depends on where you're tight, where you're loose. You have this graph where you can just adjust your tibia and your femur depending on where you're tight, where you're loose, and in which position as well. So once you get used to this, do 3-4 cases, you know how you can adjust your implants to get your ideal graph. Then there's the cartilage mapping, where we want this nice transition between the cartilage and the implant, which we can also do with this robot help. Implant tracking, we're always afraid of edge loading, especially in the fixed bearing implants. But with this implant tracking feature, we can make sure that it's always centrally tracking femur over the tibia. As you've seen, the burring is done with the robo. Now with the planar workflow, 2 cuts with the saw and the remaining by the burr, so it's a little bit more ergonomic for the hands. And the trialing is done. We can again check the limb alignment, joint gaps, and the range of motion. And of course, the final cementation. So with the MAKO, we can also do lateral unis, we can do patellofemoral, we can do bicompartmental as well. And of course, if all these are still not indicated, you go for a TKR. So you have the freedom to do any of these procedures. Till now, we haven't done any lateral compartment unis yet, because we don't have those many indications in India. So what about procedure time? Not only are we time neutral, but we're actually faster. 35 minutes is my average time. What does it mean for the patient? Yes, it does help the surgeon for sure. Does it really reflect in terms of patient outcomes? We've got reduced surgical time and blood loss, unparalleled accuracy in implant positioning, smaller incisions, less pain due to reduced soft tissue dissection, and faster recovery. So what does it mean for them? These are the striker studies. Less pain in the 90-day period, you can see robotic versus manual, manual being the purple and robotic being the blue. You have much less pain in 90-day period. You have 92% satisfaction at 2 years. You have again minimum 2 years and minimum 5 years follow-up in the yellow. Less is everything. They keep saying that. Less bone and soft tissue damage, less need for analgesics, less time to discharge, less need for physical therapy, and less post-operative pain. And if you see this paper by Bell et al., where you have gray as a manual and yellow is the MAKO, in all the 6, that is femur, sagittal, coronal, and axial, tibia, sagittal, coronal, and axial, in all the planes, the accuracy was higher with the MAKO. What about the, I'm not going to go into too much details because all these papers are saying the same thing. Gait comparison, there's no significant difference between a healthy knee and a partial knee with the MAKO. So that means you're almost completely restoring the gait to pre-surgery levels. Learning curve, MAKO-assisted uni has a shorter learning curve than a conventional uni. That's an important point. Adopting a robotic uni is much easier than a conventional. And what about our outcomes? This lady is a day 2 after surgery. This is one of the first patients we did with the MAKO, and she's sitting on the floor and talking. That's when we were convinced that this is really a good procedure. This gentleman is almost 89. We did both the knees, partial knee with robotic. He sent me this picture, video after a week. This man is 80 years old. He wanted to get back to playing golf. He had medial arthritis, and he sent me this video a month after. I don't know how good he is at golf, but at least he was able to play. And he sent me this video. And this is one case I want to show efficiency accuracy. Just another minute. This patient came to me just last month, a friend's mother. She had these implants in situ, and I was sure that I want to go for uni because there was no collapse in the valgus. So this is a bit of planning that I could do beforehand. I wanted to see if I can get away without taking a single screw. So this is a pre-op planning. I have not even taken the case in yet. I know probably some of you may not venture for a uni in this case, but I was quite convinced. All I did was I just checked where the screws are hitting the implant in all the 3 planes. You can see it is hitting this posterior screw. So what I did was I checked through all these slices. Okay, and then what I did was I make sure that in all the planes it's in the same position. Okay, and if you can see here, I made it a little more proud so that I'm not hitting it over here. I sent the tibia up a little bit so there's no hitting the screw during the cut. I also anteriorized my tibia so that I'm between these 2 screws. Okay, so make sure I'm not hitting the screws in any plane. And once I was convinced about these, I went ahead with my cuts, and I also made sure that my lug holes are also not hitting these screws. And of course, I went ahead with the plan. The saw made sure that it's not hitting any screws when I went ahead with the sawing part. The femur anyway, there was no issue whatsoever. And of course, at the end of the day, I managed to get away without touching any of the screws with a perfect fit, and had a very happy patient after that. So why are we getting better results? Probably we're maintaining the internal homeostasis of the knee. Haptic control gives less inadvertent soft tissue injury, and we're definitely not overstuffing the joint. That's how it's helping. And we're doing a study right now where we're comparing radiological and functional outcomes of robotic versus conventional partial knee. We've studied around 200 cases. We should be publishing this next year. Thank you so much.